Hi everyone, welcome to week 2. This week is a short reading. It's from page 853 to 857 in your text, and it covers a lot of definitions and terms within pharmacology. So hold on tight, get comfortable with those definitions and how drugs work, because it's a lot of information packed into 5 pages. So pharmacodynamics. Pharmacodynamics refers to the study of the effects of drugs on living organisms. So every individual unique drug exerts its own forceful and specific action on the body by forming a bond to protein molecules or chemical groups found on a cell, either on the surface of the cell or within the cell. So these proteins or sites are referred to as receptors, and each receptor has a unique design. Receptors are normally activated by neurotransmitters or hormones. An example of this would be of a neurohormone in your body would be something like norepinephrine, which is basically the autonomic nervous system's neurotransmitter that allows your body to sort of fight or flight. And that has its own receptors within the body. Another example would be acetylcholine, and that binds to acetylcholine receptors and causes its action. So those exist naturally within the body. So drugs mimic these hormones or neurotransmitters, and they are able to fit into the receptors as well. So to bind correctly with cell receptors, drugs must have a similar or complementary chemical structure to that of its receptor. And we measure how well it fits into that receptor by a term called affinity, and that just means how tightly a drug attaches or binds to a receptor. When it binds to its receptor, it creates a signal for the cell to function or respond in a particular manner. The tighter the binding, the better the result. So drugs that bind to receptors and affect cell responses are referred to as agonists. We think of them as activating drugs, while drugs that prevent cell response are called antagonists or blocker drugs. Sorry, I forgot to switch the slide there. Agonists mimic or enhance the action of the receptor, whereas antagonists block or inhibit the action of the receptor. So let's give you an example of an agonist. One that the book uses, which is a really great example, is albuterol, which is a beta-2 agonist. And what that does, when albuterol binds to a beta-2 receptor, it results in an activation that causes relaxation of muscles lining the airway, and it stimulates the bronchial tubes to dilate, so it's a great drug to use in asthma. I'm going to use a different drug that actually acts on the same receptor to give you an example of antagonists, and that drug is, the class of drug is called a beta blocker, and beta blockers are used in blood pressure. So there are beta receptors, as you can see from agonists, there are beta receptors in your lungs, and there are also beta receptors in your heart. So the ones on your heart, when they're blocked, cause a reduction in heart rate. So a beta blocker such as metoprolol will bind to a receptor called a beta-1 receptor on the heart and block the action from happening. So instead of the heart speeding up, it slows down. So here we have a little picture that'll kind of explain this in visual terms. The first one is the before the drug, so a normal everyday functioning. So let's pretend this drug is, we'll say it's norepinephrine. That's the little green, this neurotransmitter is norepinephrine. The little green circle, oval, what have you, is going to bind to its receptor site and cause an activation within the body, within the cell. So let's use our agonist drug as an example, the one we used from the page before, albuterol. Albuterol is the little purple, right? And it can bind to beta-2 receptors in the lungs and cause an increase in chemical activity. In this case, the activity would be that opening of the smooth airways, the relaxation of the smooth muscle, sort of allowing the person to breathe better. In our third picture, all the way to the right, we have an antagonist drug. So let's go back to our beta blocker. Beta blockers act on beta-2 receptors in the heart, and they cause a blocking of the receptor. So the agonist blocks the receptor site, and therefore our little green norepinephrine can't access that receptor and cause the heart rate to speed up. So hope that makes sense. Just think of agonists as activators and antagonists as blocking. Okay, dose response. So drug manufacturers have a lot of tests that they have to complete on a drug prior to the drug coming to market in order to determine its risk to benefit ratio. In other words, how safe and effective is this drug, and at what levels is it safe and effective? So the manufacturer must determine the drug's therapeutic index, and that is the range between the therapeutic dose of the drug and the dose at which the drug becomes toxic. So on the picture to the right, the therapeutic dose, the therapeutic range would be those dashed lines, the area in between the dashed lines. Anything above the top dashed lines is toxic. Anything below the bottom dashed line is ineffective. So that's what we call a therapeutic window or index. You will hear it referred to more frequently as a window more than an index, but that's just clinical terms. So some drugs, such as non-opioid pain relievers, have what is referred to as a drug ceiling. A drug ceiling is the maximum dose at which the drug will provide its greatest effect. Taking higher doses than those listed as the maximum dose on the drug's label will provide no further therapeutic value and in some cases may cause harm. So opioid drugs, such as morphine, do not have that ceiling effect, and they're used in patients that are terminally ill to manage pain that is beyond excruciating. Let's go back. The bioavailability of a drug refers to the extent to and the rate at which the drug enters the blood plasma and is made available at the site of action. So the bioavailability is basically how much of it is available once the drug is absorbed. So when you put an intravenous medication in, all of the drug gets put right into the bloodstream. So 100% of the drug is available right away. When somebody takes a medication by mouth, not all of it will get absorbed. In many cases, a lot of it will, but maybe not all of it. And in some cases, hardly any of it gets absorbed. So you will see bioavailability of drugs range from low, like 10%, all the way up to 90, 95%. But remember, IV drugs always have 100% bioavailability. Okay, so next we're going to talk about dose response curves. So this figure here is an example of a dose response curve, and it's the time it takes for the drug to reach its peak plasma level following the oral ingestion of a drug. So what we see on the x-axis is time, and the y-axis is drug concentration in plasma. So as you can see, time 0, the patient takes the drug, it gets absorbed, it peaks at the plasma level right about here, and then it starts to be metabolized and excreted from the body as time goes on. So time to peak for this drug would be about a little more than 1.5 hours after it's taken. So if we talk about IV drugs, top one would be a PO drug. If we talk about IV drugs, this is going to look more like an IV drug dose response curve. Time 0 is the time of injection. All of the drug is available at once, and it works its way down. It gets metabolized and excreted. So there's none of that absorption. It's just there, and then it slowly starts to go down. So peak plasma level is always time 0. Okay, so drug actions. Drugs may be grouped by the type of action they produce in the body. Drug actions include the following. A local action. The drug acts on the area of tissue in which it is administered. For example, you might have had stitches in the past, and in order to give stitches without putting someone in extreme pain, we inject lidocaine. It's going to numb the area. Same idea when you're getting dental work done. Lidocaine numbs the area and exerts a local action. It doesn't numb your entire body, just that area that it's injected to. A remote action, the drug has an effect in a different location of the body than where it was administered, such as a nerve block, for instance, which is where they inject a block within the spinal cord to kind of cut off anything from that point and below. So the drug can have a systemic action, which is where the drug is absorbed into the bloodstream and carried to other parts of the body. And this can happen with oral medications such as antibiotics. It can happen with pain medications. Many medications can exert a systemic reaction. So let's talk about drug effects. While the primary effects of therapeutic drugs may be beneficial, other effects from particular drugs can be detrimental. You'll hear something referred to as the risk risk-benefit ratio. So does the benefit of the drug outweigh the risk of taking it? Because every drug has side effects, so we have to take that into account. So the therapeutic effect is the desired effect that a drug has on the body. A side effect is a secondary effect in addition to the therapeutic effect. Sometimes side effects can be good, and they can end up causing other uses for the drug. However, most side effects are unpleasant and may even be harmful. These are often referred to as adverse effects. Drug interactions. Drug interactions occur when one drug diminishes or increases the effect of another drug. So these are usually can be warned about in the programs that we use to enter orders. We can have drug interactions pop up, and they can be as minor as, say, increased drowsiness, or as major as, as major as sudden death from an increase in potassium. So we always keep an eye out for drug interactions, and it's a pharmacist's job to determine how severe the interaction is and if the risk outweighs the benefit, and then not to use the drug. Finally, a drug allergy is an allergy to a drug that occurs when the body forms antibodies against specific chemicals in a drug, stimulating an allergic response. When you think of allergies, you think of hives, anaphylaxis, difficulty breathing, swelling. However, sometimes it can be a local reaction where it's something as simple as itching, a rash, or just localized swelling. Whenever somebody has an allergy that involves swelling to their airway, hives, or any sort of difficulty breathing, we never want to administer that drug or anything similar to it. And a great thing that you can do as an MA is to feel free to call the pharmacist and ask them, my patient's allergic to this drug. Is it okay that I'm about to give them this drug? Especially if they sound similar or look alike. A systemic reaction occurs when the entire body is involved. This would be called anaphylaxis. And again, we talked about swelling of the tongue or throat, inability to breathe, bronchial constriction. These are life-threatening emergencies that require immediate treatment. Last but not least, pharmacokinetics describes absorption, distribution, biotransformation, or metabolism, and elimination. You'll hear it referred to as ADME. So 4 processes that affect the drugs is absorption. We'll start there. This is the process by which the drug passes into the body tissues or fluids. This process depends on how the drug was administered, gastrointestinal function, and the chemical makeup of the drug. Distribution. This is the process by which the drug is transported from the blood to the intended site of action. So how far does it go? Does it get distributed to all the tissues? Does it get distributed to just the bladder? Does it get distributed to the brain? Biotransformation, more commonly referred to as metabolism. This is the process in which the drug is chemically altered and undergoes changes in order to be utilized as intended by the body. This process occurs in the liver for most drugs. Healthy liver, good metabolism. Not healthy liver, bad metabolism. Elimination. The process by which the drug is excreted from the body. This is mostly through the kidneys. It can also occur through the GI tract, respiratory tract, the skin, and the mucous membranes, as well as the mammary glands. So hopefully that kind of gives you an idea of how drugs move throughout the body. The last part I want you to go over is Table 30-2 on page 857. And that talks about factors that affect drug actions. We all have individual unique factors, whether it's our age, our sex, our weight, comorbidities such as diseases like diabetes or chronic obstructive pulmonary disease, medications that we're on. All of these individual factors affect how a drug acts. So get familiar with that table and find out how, maybe the timing of the drug affects how it works within the body. I'm not going to go over it point by point, but you definitely will need to. So I hope you guys have enjoyed this week. A lot of good information here. Email me with any questions, and don't forget, by the end of week 2, you are to turn in the week 2 assignment, complete the week 2 forum, which consists of 1 original post and 2 responses, and there's extra credit on MindTap, that crossword that you can complete. I believe you still have this week to complete the syllabus quiz as well. And I look forward to seeing you all next week.